It's a notorious fact that cerebrovascular diseases are the main burden in the Balkans and especially in Bulgaria when it comes to mortality and morbidity. According to the local governmental data and the national fund data, approximately 37,000 cases of cerebrovascular diseases are being diagnosed annually, which means that it's high likely for you to encounter SAH patients if you're dealing with this pathology. Couple of words, who are we and what do we do for a living? We are a small hospital, a neurovascular dedicated center with, within our department there are 2 biplane angios dedicated for neurovascular procedures. We provide services for a variety of cerebrovascular diseases, or in particular ruptured and unruptured cerebral aneurysms, brain AVMs, fistula, and spinal vascular pathologies. Unfortunately, we do not have a dedicated emergency room nor a stroke care unit, so we are unable to provide stroke treatment and mechanical thrombectomy for our patients so far. When it comes to our protocol for dealing for the treatment of acutely ruptured and wide neck cerebral aneurysms, we usually start with simple coiling. That's a really effective technique, but sometimes that's really not that much. You cannot build a stable basket inside the wide neck aneurysm. So as a second treatment option, we rely on the well-known balloon-assisted coiling. It's really effective and considered safe, but sometimes this technique poses some serious limitation in terms of navigation into the distal vasculature or thromboembolic complications due to the occlusive nature of the microcatheter balloon. When it comes to recently introduced device, we do have some solid experience with the temporary neck bridging devices, the Cascade and the Comaneci stents. Both of them are temporary, manually controllable implants that are aimed to reconstruct the aneurysm neck, so you can achieve better coiling and better occlusion rates inside a complex aneurysm. And as a last resort in our department, we use combined approach with the implementation of microcatheter balloon and the Comaneci or Cascade device. We call this technique the hybrid technique. So for the sake of entertainment, I'm going to show you like 10 cases, most difficult cases we successfully treated during the last few years. This is a case of a ruptured acome aneurysm. It is a tiny little aneurysm, but with extremely wide neck open to the A2, A1 complex. What we did over here is we embolized the aneurysm with balloon-assisted coiling. It was highly effective, and you can see the compliant nature of the balloon successfully remodeling the neck. Therefore, we managed to completely occlude the aneurysm sac with the, as you can see on the final DSA. Another patient that was treated with balloon remodeling, it was acutely ruptured right PCA aneurysm. Actually, we approached the patient for simple coiling. Unfortunately, due to the presence of a second lobula of the aneurysm proximally located, the coils were kind of unstable where they were protruding to the parent artery, and therefore we introduced a microcatheter balloon just beneath the aneurysm neck and successfully coiled the aneurysm. When it comes to new devices, that's the notorious Comaneci device. That's the manually controllable handle. You can adjust the level of expansion of the device. It's a non-occlusive braided mesh that offers temporary protection of the parent vessel in incorporated branches, or and remodels successfully the aneurysm neck. It's fully radiopaque and it's quite easy to control. I'm going to show you some classical examples from our practice. That's a acutely ruptured mid-basilar aneurysm that was kind of difficult to coil though because of the wide neck. You can see up to almost 7.5 millimeters in diameter. So what we did over here is we implanted this device across the basilar artery and the aneurysm neck. So we successfully coiled the aneurysm What the device did is it kept the basilar artery patent during the embolization because it's non-occlusive, and successfully remodeled the neck, gave us enough support to occlude the aneurysm with the embolizational coils. Another tough case, I think that's the most challenging Comaneci case we did ever. It was a double rupture, actually. The patient had two intraparenchymal hematomas next to each other. Our strategy was to embolize both of the MCA aneurysms in one endovascular session. So we approached the distally located aneurysm first. As you can see on the 3D reconstructions, although there is a well-defined sac, the presence of the wide neck is really wide, and there is a presence of branches. The proximal M2 branches are incorporated inside the aneurysm. So we were unable to achieve a stable coil basket inside the aneurysm without any sort of protection. So what we did over here is we implanted the Comaneci into the upper branch of the aneurysm. Therefore, we managed to successfully occlude the distally located aneurysm, and we moved to the proximal one. That's the second option we got in our department. It's called the cascade occlusive net. I gotta say that both devices are, like, conceptually speaking, they are the same, but meanwhile they are extremely different because I don't know if you noted, but the Comaneci contracts in crescent-like shape, and the tip is kind of flexible. Sometimes it can cause like device-related vasospasm. But the cascade device contracts back and forth, and its actually mesh is kind of denser than the Comaneci. That's ruptured ACOM complex aneurysm. We had some troubles to successfully maintain stability of the coils inside the sac. So what we did is we implanted the cascade device across the A1-A2 transition and successfully embolized the aneurysm. Another classical example of cascade coiling, that was a really old lady with a nasty-looking aneurysm of the vertebrobasilar system. What we did over here is, we actually were really desperate about this case because you can see that the neck is really awful, and the whole morphology of the vertebrobasilar system is, yeah, ugly looking. So what we did over here was we catheterized the sac and successfully implemented the cascade device across the vertebrobasilar system, and we completely embolized the aneurysm. These are the final results. The devices are really good. They are controllable. You can manipulate with the porosity of the mesh. They are easily visible. You can see on the fluoroscopic images over here. When it comes to like complex aneurysms located at the level of bifurcations, we use that fancy hybrid technique we call. That's a ruptured ACOM aneurysm. The problem here was the fact that both A2 were next to the aneurysm neck. What we did is we successfully catheterized both arteries, and we placed the extra compliant balloon in the lower branch and Comaneci device in the superior branch. It's a really good technique because it combines both the ability of the microcatheter balloon to reconstruct and obstruct the blood flow, and then you have the Comaneci next to the microcatheter balloon. This is the final result with the complete obliteration. Honestly, I think that's actually the second year follow-up or something like that. So the result was really pretty good. Another case example of the simultaneous application of microcatheter balloon and Comaneci, wide neck basilar tip aneurysm that was approached with balloon into the right PCA and Comaneci device into the left PCA. You can see how well both devices reconstruct and bridge the neck, and therefore we managed to obliterate the aneurysm with coils. Then that's the final result with full patency of the vertebrobasilar system. So the summary is, yeah, coiling is efficient, I gotta say, but sometimes it's really difficult to like completely obliterate the aneurysm with only coils. So nowadays there are a variety of new devices available on the market, and we would like to highlight that the learning curve with those devices is extremely important and essential for your success. I would like to thank you with this impressive piece of art of ours that we managed to publish on the front cover of the Neurosurgery journal. Thank you very much.
Thank you, Dr. Sirakov, that you also managed to be in the time without any delay. So any questions from the audience?
Are you giving aspirin if you use the Comaneci?
No, Professor. From what I know from the literature, there was a German group that actually did Comaneci in non-acute scenarios, Dr. Fischer or something like that. Our experience with this device or any temporary bridging device under the circumstances of SAH is without any mono or dual antiplatelets. We just do regular heparinization at the start and that's it.
But you give heparin?
Yes.
But you give heparin.
Yes, yes.
I can add that because that was completely new device, which we have to start like pioneers. They advocate that we have to put a dual antiplatelet therapy to do elective cases. I didn't want to start with elective cases of the device. I didn't want. So the first like 20 cases was only rupture cases in acute scenarios. So we didn't put aspirin for them. And we managed to conclude after more than 160 patients.
Yeah, something like that.
80% of them acutely ruptured. We don't need aspirin. We didn't see more complications compared to the balloon-assisted.
Yeah, the thromboembolic complications from this technique are relatively rare. Maybe the only complications we've seen so far is the dreadful movement of the tip. Sometimes it tends to migrate or irritate the vessel that's distally located. The solid argument towards no antiplatelets was the open cell design of the semi-looking stent and the fact that it doesn't walk the blood flow inside the parent vessel across the aneurysm.